Hi, everyone. Welcome to April's webinar. My name is Jen Braun, and I direct the AHA Team Training Program. We have a really great presentation today addressing the elephant in the room, shame and Sentinel emotional events in healthcare. So before I hand it off to our speaker today, just a few rules of announcement, or a few rules of engagement, rather. You can listen to audio by either listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom to switch to either phone audio or computer audio. Please note that everyone's in a listen-only mode, and all hyperlinks on the screen are live, so you can keep that in mind. If you'd like to click on that, it will open in your browser. And then finally, I will moderate a Q&A session at the end with our speakers. So if you have questions, please chat them in throughout the presentation. If it's technical or logistical, we'll answer it in the moment. But if it's for our speaker and more content related, we'll definitely save that for the end. As always, for our webinars, we're happy to offer free continuing education credit. And so in order to claim your CE credit, you must create a Duke OneLink account. This is a one-time only setup, and my colleague Kara has chatted in those instructions. And you can also refer to the email that was sent to you this morning with the attachment. And so following the webinar today, please text the code you see there, RECBAB, to the number on the screen, and we will share this at the end. And again, this window opens following the webinar. And so in terms of upcoming events, registration is open for the remaining courses for the first half of the year for our Team Steps Master Training. We highly encourage that you attend in a small team, as we've made enhancements to the course to include human-centered design thinking. So you can work with your team and you'll walk away with a strategic and tactical plan for implementing team steps. If you want to become a master trainer, but you're unable to attend in person, we have a virtual course that spans 8 weeks that kicks off here next week, actually. There's still a few seats left. And so the format of the course is that each week there's asynchronous or on-demand learning that is usually about 30 to 60 minutes that you can do on your own time. And then the class meets live on a Zoom session on Thursdays to discuss, practice, apply what they learned during the asynchronous portion. So registration is available, and the link for the courses will be chatted in. If you're looking for a more customized training solution, we offer on-site trainings where we can come to you, to your organization, to deliver anything from a 2-day master training course to a more comprehensive training program, which would span multiple on-site trainings and virtual coaching to really help support and create ownership within your organization. And really, this allows us to customize the content to fit your needs or your audience. And then you can visit our website to learn more and complete a brief questionnaire, and one of our team members will follow up with you to get started on a solution that is tailored to you and your organization. And then finally, in terms of our webinars, our May 10th webinar will be announced soon, so keep an eye out for that. We have a bonus sponsored webinar by the Physician Committee for Responsible Medicine on April 26th, that focuses on plant-based options on patient trays and using that as a teachable moment. So that's really about putting the patient and the family at the center of the team. So registration is open for that. So now, without further ado, I would like to hand it off to our presenter from Duke, Dr. Will Bynum, who is the Associate Professor of Family Medicine, who will be presenting for the next 55 minutes or so. So Will, I'll turn it over to you.
Great, thank you. Thanks so much, Jen, and thanks to all of you for being here today. For the chance to speak with you. It's really an overwhelming level of involvement from all of you, and to the AHA for this just wonderful opportunity. Also, a special thanks to Aaron Eckert at Duke and my colleagues at Duke who have advocated just so much for this topic and really who catalyzed this chance for me to speak to you today. I'm a family physician, medical educator, and early to mid-career researcher who study shame and particularly in medical education, but more broadly in healthcare. And this talk today is going to be sort of an overview of this topic, of some of the work we're doing around it, and some things we can begin doing about it in our environments, irrespective of your position in your institution. I have no disclosures to report. The objectives for today are relatively simple. The sort of the overarching objective is to put this emotion on your radar. And that's not going to be hard because as a fellow human, you have undoubtedly experienced it. Where it tends to fall off our radar is its experience within the milieu of providing clinical care, within the really challenging environments in which we work and learn. And this emotion that often pervades our ability to recognize it, acknowledge it, and then engage with it. So the overarching objective is just to put shame on your map and to consider how it may be operating in your environment. More specifically, I'd like for you to understand the difference between shame and guilt and why that difference matters. I want you to have some conceptualization about how shame can occur within a healthcare environment, the things that can trigger it, how it might feel, what it makes us want to do. And then importantly, to walk away from this with at least a couple of specific strategies to begin operationalizing the content that I communicate. This is a teaser presentation. There are hours and hours and hours of workshopping and engagement that we could do around this topic. And I can point you to some additional resources, but for today, I do want you to try to leave with at least a couple of specific strategies that you can begin employing. And so in the spirit of bringing this elephant in the room, which was termed by Davidoff back in 20 years ago when he wrote about shame, describing it as something so big and sort of present that we can't help running into it, even though we're not aware of its presence, that it is this pervasive, powerful emotion that is operating, but often operating out of our awareness. And so in the spirit of bringing this into the light, I'm going to start by giving you one of my own experiences of this emotion, which really led to the work I'm doing today, and to carry through that story and then the rest of the presentation, I'm going to use the metaphor of fire. And it's a metaphor we've used in our qualitative research to help conceptualize how shame can manifest within and affect an individual and the environment in which that individual is working or learning. And so if we consider shame to be a reaction like a fire, then I would argue, and our data would suggest, that the act of practicing and learning medicine, nursing, allied health, and healthcare is sort of like a pile of matches, like a big pile of matches, just waiting for one to be struck. The work that we do, the stakes that are involved in that work, and the nature of that work brings with it inherent, if not inevitable, but inherent risk of challenging emotions like shame. And I'll tell you that when I first kind of became painfully aware of this possibility when I was a second-year resident. And I was early in my family medicine residency training, and I was on a labor and delivery shift, 24 hours into the shift, about to go home. And a patient came in having a placental abruption, which is an obstetrical emergency, as many of you know. And a long story short, the baby was in distress, its heart rate was low, its blood supply was threatened. And before I knew it, I had been pulled into the room to practice managing this challenging but very real obstetrical emergency. I was doing it without a lot of experience, without a lot of sleep, and without a lot of confidence. And in the midst of a very chaotic scene of a lot of people in the room, a lot of blood, an incredible sense of urgency to resolve the situation, I found myself delivering the baby. And I was delivering it with a vacuum assist device, which helps to expedite the delivery by essentially pulling the baby out of the mother's body. And thank God, I mean, really, thank God, I in the process of that delivery, I did deliver the baby successfully. But in the process of doing that, I caused a very severe, really severe maternal injury, like well beyond what would be considered, unavoidable side effect of a vacuum assist delivery. This was something that immediately, everyone around the bed, and there were a lot of people, and me more than anybody, knew something had just gone wrong. And if you've ever been in that situation, and you put yourself back in your shoes, you can probably remember what that immediate feeling felt like. I mean, it's overwhelming. There was a lot of fear, anxiety, fight or flight symptoms, sympathetic activation. One of our participants described it best, who said, it's like my guts fell out on the floor, or someone sucker punched me right in the stomach. You kind of, the air leaves your body. And so there's a bit of almost like an immediate shock to it. And that occurred for me. And if I recall the imagery of this, I remember feeling like I was under this big bank of operating room lights. They're bright and they're warm, and there's nowhere to hide. And then just remembering the eyes of the people around me, that's what I remember most. And I remember how they betrayed essentially what they were feeling about me or thinking about me, which was disappointment, or being horrified, or being let down, being sad. I mean, really feeling acutely judged. And the only thing I knew to do in that moment was to leave the room. I mean, to disappear. I just could not handle the emotional upswell that was happening. And that was very unlike me to do that. And that was in and of itself a challenging dimension of this. So I handed the baby in the vacuum off to the obstetrician, who took over, and I just quietly left the room. And when I got outside, I was in nothing short of a daze, feeling disoriented, kind of depersonalized, not knowing what to do next in this emotional state. And the only thing I knew to do was to get away from that room as far away as I could. And so I ended up wandering around the unit essentially until I got to the farthest point from the delivery room, which was a meditation room, ironically, and somewhat painfully, and ended up on the other side of a chair in the corner on the floor, and head in hands. And I stayed there for a couple of hours, trying to figure out what to do next and feeling an incredible range of emotion. And as that initial upswell of emotion died down, and I began to think a little more clearly, that's when the more challenging self-evaluation and emotional experience set in. And if we consider the event to be like striking a match, and the immediate emotional reaction, like a gathering fire, this was now a forest fire. I mean, this was a brush fire that was really starting to rage and was out of control internally. And that brush fire consisted of some very challenging feelings and thoughts about myself that I had not really had before, and that I was totally unprepared for. I felt incompetent. I felt unworthy. I felt like a bad doctor, bad resident. I began to think about all the success I'd had to that point, and I was, many would have called me a golden child resident, which I don't recommend being. It's actually a very lonely place to be. And anything I had sort of done to that point to engender trust in me was suddenly gone, evaporated. I couldn't see it. I didn't believe in it. And I thought that other people couldn't see it either. I was really scared of judgment. I was perceiving already that people were talking about me. This was a unit that talked about people when they weren't there. And I know because I heard them before I made my error. And so I knew they were just going to be doing the same with me. And ultimately, I began to really question my belonging and my own worthiness of being given responsibility and of being granted trust. And not to caveat that feeling of questions about belonging by saying that was me as a white man in medicine. While those feelings were very acute, never did I question my belonging because of who I am, or because of my race or my gender or my sexual orientation. I'm a cisgendered heterosexual man in medicine. What we know is that in times of intense shame, often people who are outside of those dominant norms, their shame can be amplified further by those experiences of being outside of the norm, and that those experiences and those realities for folks preying on that feeling of I'm not good enough, I don't belong, I shouldn't be here. For me, I actually had, even in the midst of a very challenging experience, a degree of emotional privilege, and that I did not have to question those things about myself as contributors to my shame or my error. And so this years later, in researching the phenomenon of shame in medical residents, we came up with this term that really describes this experience well, and so many experiences that we've learned about in our research. And that is, this was a sentinel emotional event for me. Sentinel events, as you all know, are those events in healthcare in which there's an unanticipated or poor outcome or an error that harms a patient and can lead to significant morbidity and mortality in the life of that patient. Well, these are events that are unexpected, that are really intense and challenging, that bring with it a degree of emotional morbidity for the person experiencing it. Patients can certainly experience sentinel emotional events, but the kind that we're focusing on today are the ones that are experienced in us as healthcare professionals or trainees, within the really challenging experience of learning and practicing medicine. What I learned in the aftermath of this error, and through a recovery that ultimately was successful, and through which I grew a lot, was that this emotion had a name. This experience had a name, and that name was shame. I discovered it, like so many, through Brene Brown, who's just had a transformational impact in terms of the awareness of shame in pop culture and in our daily lives. And that awareness and that definition was transformational for me. It gave me something to ground myself in, something that made my feelings real and that normalized them, across the human experience in which these emotions occur. I learned, as I then researched it further, that shame is best defined or described for these purposes from psychology is a painful emotional state that occurs when we engage in a self-evaluation. So we actively consider who we are as people, often in response to a triggering event, and we then determine or conclude that there is something global about us, something about us that is flawed or deficient or unworthy, that was the reason for that triggering event that led to that self-evaluation. Okay, and so shame, by definition, especially in keeping with what's called the self-behavior distinction in psychology, is an emotion that occurs in response to a global attribution to the self. Okay, so something about me that is stable, that is difficult to change in a moment, that relates to me as a whole person, my intellect, my competence, my capability, my attention to detail, how hardworking I am or not, my looks, my attractiveness, my worthiness. These are global descriptors of me that in my shame state and in my error, I was attributing as the cause of that outcome for the patient. This is described most simply as I am bad. When you feel shame, you are the problem. You see yourself as the problem or something major about you as the problem. And I'm going to tell you the therefore that follows that in 1 minute. First, I want to contrast this with guilt. So guilt also can be triggered by a specific event. It occurs when we recognize ourselves as having fallen short of our expectations or standards, just like shame. But rather than blaming a globally flawed self, we blame something specific, something circumstantial or situational or behavioral, something that is unstable about us, meaning modifiable in a moment, not global, and something that we theoretically can change. So whereas shame causes us to feel like we are bad, we are the problem, when we feel guilt, we say we did a bad thing. And we can feel terrible about that, and it can feel just awful, but it's the thing we did that was bad, the behavior, the action, rather than something about us, the whole person. And so why this matters so much from a theoretical perspective, and then also a practical perspective, is that when we feel badly about falling short of a standard, when we've transgressed in some way, and we attribute it to something specific that we can fix, that provides not only motivation, but a roadmap for going about fixing it. So guilt, and this is a large body of psychology supporting this, tends to drive more reparative, growth-oriented, and healing behaviors. Okay, so in my case, a guilt response would have been to feel awful about what I had done to the patient and her outcome, but to have attributed it to the fact that it was my second only vacuum assist delivery, that I was awake for 24 hours, that I didn't speak up and tell anybody I was uncomfortable or didn't know what I was really doing, that the baby and the mom were hemorrhaging and you couldn't see anything. I mean, it was probably a huge success just to deliver the baby, and then this was just an unfortunate outcome. Had those been the attributional focus for me, in order to dissolve or manage that feeling of, God, I've fallen so short of who I am and who I want to be, and to make it right with the patient, the natural tendency would have been to go and practice, to go learn more about what I could do better next time, to understand what I didn't know about vacuum deliveries, to go speak to the patient and potentially even apologize, which is hard for us to do, especially in a litigious environment. right? And each of those would have given me chances to take steps closer to who it is that I'm trying to be. They would have allowed me to engage and to heal and to learn. And so in theory, and we find empirically in practice as well, guilt tends to be a more pro-learning, pro-engagement emotion, okay? When we feel shame, when the attributional focus is on something global about us, that is a painful place to be. It's a hard place to view and see ourselves. We naturally want to hide. We want to disengage. We want to isolate and avoid future triggers or episodes that deepen that self-view. We want to avoid seeing ourselves through other people's eyes, right? By simply presenting ourselves in front of them the way we are currently viewing ourselves. We want to self-protect. We don't want to continue being injured in a way that shame can induce. And so shame, most often, especially when it's pathologized, meaning when it's inappropriately experienced or chronic or overly intensely experienced or wielded as a weapon, it tends to drive more disengaged, anti-learning, and isolating action tendencies that follow. Okay, two very brief caveats among a host of them. I don't want to suggest that this is an either-or situation. This is an oversimplification. In any emotional response to a trigger, there's likely a balance of these in some way, and a host of other emotions. I have a sick 4-year-old who doesn't sound so sick downstairs. Sorry for the background noise. The other caveat is that I don't want to suggest that shame is a bad emotion and guilt is only good emotion. We need shame to function. It's critically important. It's a very powerful motivator of behavior change and telling us when we have erred outside of group norms and then bringing us back into those group folds. But it can be very easily pathologized. Guilt at the same time can be very constructive, but I do not want to suggest we all try to walk around feeling guilt all the time. That is still a negatively valenced emotional state. But to the extent we can leverage guilt when we've transgressed or when we've made a mistake or error or bad outcome, there's real power there in terms of facilitating and promoting growth. Okay, so with that as a background, in the aftermath of this bad error and discovery, I came to see what I've now come to understand is the contemporaneous presence and absence of shame in medical education and in healthcare. And what I mean by that is that there was signal for it in our literature. There was articles in medical education, not written about shame, but with shame as a signal. There was a whole host of literature in psychology articulating the nature of shame and associations that really matter to us in healthcare, like depression and burnout, and suicidality and impaired empathy. In my learning environments around me, I could see shame functioning. I could see it occurring, but nobody was talking about it. No one was acknowledging it. And thus the contemporaneous presence and absence of shame, both in our literature and in our environments. And so this led to a lot of theorizing and eventually a couple of good mentors who sort of kicked me into the deep end of qualitative research with the overall goal of bringing this phenomenon of shame and what we've been working with so far in medical learners out of the shadows and into the light. And that is really what this work is all about right now. It's just to express this emotion, express how it can be experienced, how it can feel, how it functions, in order to make it more recognizable and to engage with it. And we've done this from a fundamental research question across, a series of studies. And that fundamental question being a how question. We just want simply to know, not supposing that medical trainees or anybody else in healthcare experiences shame in ways that have already been described in psychology. We want to know from a fundamental place, how do medical learners experience shame across the continuum of their education? And from this, we can extrapolate quite a bit of information about how any human in healthcare may experience shame. That's the important thing I want to mention here is I'm going to tell you about our findings. We need to replicate this research in diverse populations across healthcare, for sure. But because this is a human emotion, much of what I present to you is going to be very relevant and it's going to have meaning irrespective of your exact position in healthcare. So this ultimately formed my PhD dissertation, which I defended just a couple months ago. And it essentially was conducted across three studies, three populations of medical learners, medical residents, and then medical students, and then pre-medical students. And we used a methodology that I'm only going to mention called hermeneutic phenomenology, very, very powerful qualitative methodology that seeks to convey the nature and the meaning and the deeper essences of a phenomenon in accordance with the contextual reality in which it's situated. This methodology asks the researcher to continually attend to both the parts or the elements of that phenomenon that give it structure, and then the whole of that phenomenon, the whole of the experience, the deeper meanings, or those what are called ineffable essences, what is at the heart of the meaning of this experience of shame, and why does that matter? And I'll tell you, identifying the elements was overwhelming but easy. Identifying the essences, which is what was really challenging and has been the most sort of enlightening as we've gone through this work. So I tell you this only because I'm going to present a very brief overview of our data using the parts and the whole approach. Okay, so the first thing I want to show you is just some of the self-talk that our participants expressed in describing themselves when they felt shame. And so in these studies, we asked them to reflect on and recall an experience of shame during their training. And they wrote either a written reflection or drew a rich picture over about 30 minutes to reconnect with that experience. And then during a one-on-one interview, I engaged with them deeply, profoundly deeply in some cases, about the nature of that experience. And so residents describe themselves with some of these terms, students some of these terms. And you look across the sampling of self-talk, it really exemplifies the nature of shame. Any of these adjectives is non-specific. This does not describe any specific behavior, any specific circumstance. And if you were someone working with this trainee or colleague, and this is what they were assessing themselves to be deficient in, it would be hard to know what to fix. I mean, how do you fix inferior and worthless and not good enough and like a waste of space, right? So this is the global nature of shame that is what gives it its definition and its power. When we looked at what triggers shame, this is an abbreviated summarized list, and I would refer you to our papers to define the full list. We found a lot of shame related to patient care, not surprisingly. Some of the most profound shame was described by residents who had, in their view, done something that killed a patient. And we had 2 of our 12 of stories in which a resident truly believed that at their hands or their brain, they had killed a patient. And the shame that followed could be really profound. We also had examples of trainees who recognized having impaired empathy with a patient and felt shame for that, who showed emotion to a patient and felt shameful and shame for showing that emotion, who would ruminate about all the ways they could have hurt a patient, even though they didn't, and feel shame over the mere possibility that they could have caused patient harm. And that gets to really the sort of deep psychological complexity of this state. We found a lot of shame related to assessment and to learning. And this was particularly prevalent and sort of potent in pre-medical and medical students. Assessment being typically that which is measured objectively. So standardized tests like the MCAT or the USMLE step 1 and 2 scores, class ranks, GPAs, average, scores in medical school, even in a pass-fail environment. If that score told you how far or above the average you were, that could still be used as fodder for shame, often because that objective number provided a very clear, concrete marker of how I'm doing relative to everybody else. And if I'm lower than that, especially if this is one of the first times that I've experienced being lower than everybody else, then many of our participants experience pretty significant shame as a result of that. Somewhat shockingly at the time, I think I'm less shocked now, but we found a lot of shame related to learning. And it was shocking in 2 ways. One was that there were a lot of events related to what we consider to be normal learning events. Things like being wrong in public, struggling on a new task, being below average on a test. Things that are inevitable in the process of learning something as challenging as medicine, but yet could cause significant shame in students who experienced it, many of whom seemed somewhat unprepared for the level of struggle that they might entail, that again, as a medical educator and researcher, I saw as a normal, maybe even healthy struggle, but yet causing shame. The other sort of shocking, and I'm not shocked by this anymore, and that's saying something, we all should be shocked about this, finding about shame related to learning were the events that had nothing to do with learning, but yet were occurring during a learning process. They were totally inappropriate. like being mistreated, being humiliated, receiving microaggressions, being exposed to frank racism, being belittled, being treated harshly at a time of struggle. Events that were occurring with disturbing frequency in our studies that, not surprisingly, were causing a significant amount of shame. And what these data tell us, and you could imagine it, but what they make crystal clear, is the incredible emotional impact of mistreatment in a healthcare learning environment. And we have got to be able to sit with that awful reality that in the course of training healthcare professionals to become competent, compassionate, empathic, and connected and resilient people, we are mistreating them. We need to be able to sit with that moral tension, and we've got to be able to do something about it. Understanding the emotional impact, I think, can be a real strong motivator of that sort of cataclysmic change that's needed. And that really bridging into the shame that was related to mistreatment that we really have got to change. We then looked at why does a certain event or trigger cause shame? What were the things that contributed to the shame reaction, either that predisposed it or that amplified or increased it once that it occurred? And again, this is an abbreviated list, but these are some of the more sort of potent and prevalent. Perfectionism was all over our data set. If you think about shame occurring when we fail to reach a standard, if our standards are so far out there that they're not achievable, it would theoretically, at least, influence the degree to which and the frequency with which we may experience shame, especially if we attribute those failures or perfectionism to something global about us. Rampant comparisons to others, particularly in pre-med and med students, and not necessarily in an unhealthy way, but in a very prevalent way. The tendency to compare oneself to others and then determine oneself to be deficient or unworthy or flawed was a common promoter or contributor to shame. This was especially the case if that comparison was inaccurate. So I only see your strengths, I only see my weaknesses. I'm comparing myself to you who's 2 or 3 levels above me and feeling inadequate or inferior, when in reality, you should be better at whatever we're doing than me. And it should not make me feel like an unworthy person, right? So not only the tendency to compare, but the way that comparison occurred was very important. We found, as I sort of referenced earlier, quite a lot of underrepresentation as a driver of, and sometimes even a trigger of shame. And this really manifesting in the experience of either perceiving oneself to be or being outside of that dominant norm, either by race or demographics or ethnicity, sexual orientation, gender identity, religion, or where I'm from in the country, whether I went to an Ivy League private school or HBCU or a state school. That experience of being outside of the dominant norm, particularly if I worried about or perceived that there was a special system that brought me where I got to, could be especially preyed upon in the midst of a trigger like underperformance or like a failed test or like being humiliated. It just layered on this sort of the self-talk of saying, you're not good enough, you don't belong here. For a couple of our participants who are from underrepresented backgrounds, simply walking in the door of the medical school on the interview day, on the first day of school, and seeing and feeling about themselves that they were underrepresented, that they were the only one like them, could trigger shame in and of itself. This opens a gauntlet to us that there is a real emotional impact, not surprisingly, but now we have clear evidence of it, of the experience of being underrepresented in our environments, such that ensuring representation and diversity without fully supporting the emotional health and well-being of all the people in our environments is not enough. We've got to instill authentic, true belonging and the ability to authentically express oneself and to find safety in the emotional experience of being in our environments. And then finally, among many other promoters in the environment itself, those environments that were psychologically unsafe seem to be strong contributors of shame. Environments in which I can't take a risk freely without fear of reprisal, without fear of humiliation, without fear of being seen as a disruptive. And so bridging over to Amy Evanson's work on psychological safety, we found clear links between psychological safety and the experience of shame. Okay, the last two elements of our data I'm going to tell you about are just a brief rundown of some of the more negative effects of this emotional state. And this is really why this matters, with the caveat that these were not the only effects we found. We did find some positive effects. Those positive effects tended to come through a transition away from the shame and into a more constructive sort of self-evaluative stance. And that is is going to be the focus of a study we're beginning now, which looks at essentially how people recover from shame. And so I want to make that caveat, because this is a tough list that I'm going to show you, that it's not all bad with shame, but the shame does have a profoundly destructive potential, especially when it's pathologized and spirals and isn't addressed. So impaired and diminished psychological and physical wellness. We heard about feelings of burnout, of depression, of feeling like a sedentary bum, as one person put it. Too much eating, too little eating, too much or too little sleep. There really could be profound physical and psychological effects. We found social isolation and impaired belonging, very much in keeping with psychology literature. And this could be disengagement from learning, disengagement from patient care, disengagement socially with friends, with family. And you can imagine this can exacerbate that emotional state, emotional distress. We found altered professional identity formation, that certain events in the course of, of shame events during the course of learning medicine could direct people away from certain areas of medicine altogether. We had a participant who was shamed significantly during a surgery rotation, and that was the end of that person's pursuit of surgery as a career, having seen herself as in no way ever receiving true acceptance in the profession. We found impaired empathy that was significant, and our data suggests that some of the declines in empathy that we see across medical training may be driven in part by unrecognized emotional experiences like shame. And finally, unprofessional behavior. And I'm going to take you into depth about this for a brief moment, because this is a very important takeaway from this talk. We had a participant who was a senior resident. His life goal was to become a chief resident. That's the standard he was reaching for and striving for, and he wasn't selected. And in the midst of not being selected, it was crushing blow to him and his ego and his self-esteem. And he developed a significant shame reaction. In the midst of that shame reaction, he reflected, I had no fortitude, I had no resilience to self-regulate, hold back my true feelings. It was a very primitive state he assessed himself to be in. And in that primitive state, 2 days later, he was in the emergency room. His attending gave him some constructive but difficult feedback, and he proceeded to publicly, loudly cuss her out. F-bombs, 4-letter words, completely, blatantly unprofessional behavior, shockingly in many ways. This landed him in a major remediation process that started that afternoon. He reflected, I remember he said, the program descended upon me rapidly later that day. And as a program director, I can relate to what he's talking about. That is a scary descent to have come upon you. But as we went through the transcript, the first half of the transcript, there was a lot of anger and denial and blame. And that's because, well, as my research colleagues on this, my co-PIs who were analyzing this with me, went through and read the first half of the transcript, they had their own reactions. And these are the margin notes from their first read. Now, I knew where the story was going, but they didn't. And so these are some of the notes they made about this individual. I don't see shame here. I see anger. In fact, this person doesn't feel particularly inclined to shame, which is a bit of a harsh thing to say about a person. Another researcher colleague said, this is feeling like a martyr complex, victim complex. And it was. He was saying that they all got it wrong. I was the more deserving chief. This person they got doesn't deserve it at all. It's all about them who are attacking me, right? So a lot of defensiveness and blame. This is my favorite quote. This guy's unlikable. I'd love to meet his wife. Now, I've read this and I was like, wow. I mean, that is a pretty significant reaction you're having to this person in reading the transcript. Now, imagine how all the people around him in his orbit on that day and the days after were reacted to him, right? Probably very harshly. And in fact, they were reacting very harshly and with a lot of frustration and anger. And that's because in this individual who was experiencing really significant shame that was completely hidden and repressed, he was putting out a different set of behaviors to the outside world that were driven by this shame, at least in part. And these were the behaviors that were being labeled as unprofessional and that people were reacting harshly to. And to no real fault of their own, you could imagine reacting this way. But that reaction only amplified and deepened his shame significantly over weeks and weeks, to a point of, probably passive suicidality, from which he eventually recovered. So this felt really important to us, that shame is an emotion that often stays hidden. It's often put behind a wall, and it manifests itself in ways that may not indicate true emotional suffering and that might prompt behaviors in us that are difficult. And so we submitted this to academic medicine. This is my drawing. I'm very proud of it. It took me about 3 times to get it just like this. And they said, this is a great concept. We would love to publish this, but please pay a professional. And so this is what we came up with. Does look a little bit better, maybe. I personally like the sad person and the other one better, but I really want you to take this away and remember that before you react to that unprofessional behavior, or when you recognize it, consider the possibility of underlying emotional distress, especially shame, and it being an emotion that might not be easily shared or talked about. Okay, so the last thing I want to do, I'm going to get a little bit of audience participation here in the chat, is I'm going to tell you just about what we found about what shame feels like. These are the elements of the parts, the phenomenological structures that we found as describing or helping us understand how shame feels. And I show you this table only to show you how incredibly complex this emotional state is and what it can require from us cognitively and emotionally in a moment. When we looked across these parts and all the various sort of substructures that they developed, to try and identify the essence of shame, this is what we found, that ultimately shame tends to be, can be, and often is a destabilizing emotional state. It's a state that throws us off of our emotional axis. Participants described it as an emotional vertigo, as like losing my anchor and being adrift out to sea, unmoored and without direction, depersonalizing, disorienting, very distressing. And that ultimately, and this is our most recent paper, that interwoven within this destabilization is a destabilized self-concept. So how I know myself to be, my identity, how I feel about myself, my self-esteem, that self-concept seems to be destabilized acutely and potentially chronically in a shame state. So ultimately, shame just gets to and affects who we are and how we see and know ourselves as people. We worked with an illustrator out of the UK named Hannah Mumby, who it's just a lovely, amazing human being and artist, to take some of the data from this study of the phenomenology of shame and to visually depict it. And so what I'm going to do, I'm going to pull the chat up here. I'm going to do my best to keep up with your responses. I will not. I'm just going to kind of apply my qualitative brain here. But what I want you to do is look at this image and tell me what you see. Reflect on it within your environment, and maybe what I've talked about already with shame. What do you think is happening? What do elements of the composition mean? Have you experienced this before? Yeah, it's interesting. One person mentions isolation, and the irony of that is that it's like isolating and exposing at the same time. Feeling worthless, being scapegoated. Other people are saying things like being, that would suggest perceived judgment, belittlement, some physical feelings, being hot, like everyone's watching you, all eyes on you, feeling inadequate, embarrassed, more judgment. This person is leaning over, this person making them feel small, right? One of the things that we have sort of come to appreciate in this abstraction or this drawing is that this person almost looks a little bit subhuman. This isn't a real normal shaped thorax. So it's almost a little bit monstrous in a way, kind of like a Guillermo del Toro movie or something. So that there's something really intimidating happening here. There's a power differential that could be suggested, being ganged up on. Somebody mentions trying to hide, but thinking that everyone can still see you and are looking down on you. Yeah, that tension of I've got to hide, but I'm so exposed. Pink Floyd The Wall, I love that. That's great. So in what we've had in other times we've used this as a teaching tool, people have reflected on is that this could be true mistreatment. It could be a real harsh interrogation. It also could be completely, appropriate. And this is how this person is perceiving it and feeling it. Some of that might be more indicative of a broader environment than a single interaction. The translucency of the white coat here is something that people picked up on that I missed initially, being like you're almost losing the worthiness to wear it. And then having the color being that upswell of emotion that can be so physical, that driving a desire to hide that and often sort of following the person into hiding, into a place of isolation. Somebody mentions here, there's a lot to unpack here from an interpretive standpoint. These people may be judgmental. They don't have faces, so it's almost like they've lost their human element. But it also could be that they're sad. It could be that they're bystanders who are also experiencing some sort of moral injury or distress, or it could be that they're truly judging them. And a lot of that probably is indicative of the nature of this type of environment. Okay, here's the next one. So this is considered to be sometime after this event, probably near time. And this is a pattern we saw with many of our shame experiences. What do you see here? What's happening? What does the composition mean? Have you experienced this? So ruminations, self-doubt, racing thoughts, isolation. Yeah, the cool color in the room, the kind of eerie light outside. I don't know if it's night or day. Heaviness, kind of drowning, internalizing. Yeah, so now we're getting sort of insight into the internalization that's happening, the self-talk that's not controllable and that is negative and consuming. Right, we identify this as the beginning of runaway thinking, of a shame spiral. Somebody mentions it's not good enough to wear the white coat, recognizing the distance of the white coat across the room, almost now like there's an impediment, a barrier between this person and that white coat and the door and the outside world. Pain. Yeah, opening the door, light would come in. Great. Next slide. The evolution of this. What do you see here? What is sort of evolving or differing? What does composition mean? How would you intervene? Distortion. Awesome. Yes. So that's one of the key elements of this is distortion. We call that the skewed frame of reference. So the real challenge and inability sometimes in a shame state to accurately assess oneself, evaluate oneself in accordance with objective reality. That you see yourself as so wholly bad or unworthy, where objective reality might say, no, you were very worthy, you just made a mistake, you did a bad thing. The shame spirals, yes, vortex, spiraling down, black holes, getting harder and harder on oneself. That what previously were self-doubts and questions are now statements and beliefs. Maybe they were whispered before, now they're being yelled or screamed. How can I go on? And you can imagine how this can become a really challenging place to be. And that distance between the outside world and maybe help and maybe unskewing that frame of reference and that white coat is growing and growing. And this we found not in all shame states by any means, but in the more intense ones this was the nature of sort of runaway self-evaluation. And this is what we want to try to avoid, right? With shame competence and the ability to intervene on this, support someone through it, support ourselves through it. And finally, what do you see here? Yeah, hope, healing, acceptance, compassion, empathy. I love it. Empathy is what really jumps out at me here. Validation by someone else, unskewing that frame of reference, forgiveness, friendliness, kindness, right? What does it mean that both of them have a glow, a similar glow here? Curtains are open, warm light flooding through, doors open, shared experiences. Yeah, recognizing the feelings of others. This person over here, maybe a supervisor, maybe a friend, someone that maybe they look up to, has been through this before and they have managed it and it has become part of them, and that is being activated as a part of the shared experience and the support that's being provided, right? And so there's this consolidation of emotion, of runaway thinking into something that doesn't disappear or go away, but that is somewhat controlled and managed, and there's an active agency happening here, and that agency and that growth and that support are being facilitated by this other person, right? Yeah, great. Okay, so we have this on our website, this series of illustrations, as well as some other tools that really are amazing for generating discussion. The discussion that comes from using this art has been really, really powerful as I've used it, and it can open up some very interesting interpretations and get people talking about their experiences with similar emotions. What I'm going to do the last few minutes and then save just a couple minutes for questions is to try, after all that, I mean, I certainly want to end on a hopeful note. I love panel 4 for that. It's like a breath of fresh air in the midst of a really challenging emotional sort of experience we've been exploring here. Just some very brief and specific things that you can do to walk away from this and begin managing this emotion in a constructive way. So the first, these are two soapboxes I'm going to jump on very quickly. The first is this one: that intentional shaming is just not necessary, nor is it effective pedagogy. Period, full stop. I tell people all the time, if you can't teach without shaming someone intentionally, if you can't practice patient care, if you can't work on a team without shaming people intentionally, you should not be in healthcare, you should not be in teaching. The emotional baggage that comes along with, and the destruction and distress that comes along with shame far outweighs any impact on learning that it may induce. Okay, I'm going to give you an alternative to shame in a minute, though, because we can leverage the negatively valenced experience of being in a shame or a guilt state. The second soapbox I'm going to jump on is that I am a major advocate for addressing burnout. It is a very real and important thing. I've experienced it numerous times myself. What I am deeply concerned about is the degree to which burnout has come to dominate our conceptualization of what it means to be unwell in healthcare. It's one of the only ways we've talked about it, and therefore one of the only things we try to adjust. We've got to be more aware of those elephants in the room that are having major impact, but are not easily measured, aren't easily talked about, and or are heavily stigmatized, like shame and other similar constructs. We're going to keep running into these things. Let's shine a light on them and at least manage the way that they manifest within our environments in a constructive way. I've given you a lot today, whether you realize it or not, time that will help you identify shame. I mean, this is one of the best things you can do or take away from this, is the ability to recognize this otherwise very hidden and stigmatized emotion. Think about the possibility that shame exists. This has been called shame-sensitive practice by my colleague Luna Dolezal in the UK. It's the willingness and the ability to maintain awareness of the fact that shame could be happening really in any person, anywhere. It's an extension of trauma-informed care, where we recognize that trauma could be a part of anyone's experience, that shame could be too. And so, especially in events like medical error, bad outcomes, mistakes, learning struggle, that it is likely that shame could be present, and to you really need to raise your antenna and your radar for it at that time. Listen for it. The words I've given you, there are a lot of the self-talk that I've expressed will be spoken to you. You will hear those words. That's a flag. Look for it. People who experience shame isolate, they withdraw, they make themselves small, they don't meet your eyes. If you're noticing those behaviors acutely or over time, a shame state may be present. And then ask about it. I love this so much. Is a very high yield, very easy strategy to employ. When you're offering to support to someone who may be experiencing shame and you don't know how to get them to kind of bring it out, go beyond this question. It's an appropriate question, but it doesn't get to the level of the self-evaluation. To this question: how are you feeling about yourself? I want you to tell me how you see yourself right now. How are you viewing yourself or feeling about yourself? That's the invitation for them to tell you, I feel really down on myself. I feel awful, like a bad nurse or a bad doctor. Or for them to say, I'm feeling okay about myself, but dang, I feel bad about this thing I did. That will give you a sense of where their self-evaluation is. And then within a trusted interaction and a compassionate, empathic interaction, you have the opportunity to help them transition that attribution and to potentially stop the spiral. To do that, name the emotion. I just heard this talk about shame, or I saw this Brene Brown TED talk, or read this book. This is a real thing. It sucks. It is a brutal emotion, but it is normal, right? It is a normal, if not understandable way to feel right now, but it's really not a constructive place to stay. Here's the time when I experienced it. Here's how I got through it, right? That, the glow that you have, let that sort of, let that light up. And then I really work with people to try and specifically transition that blame. So I'll say, take the blame off of you. I want you to be kind to yourself and put it over here on this thing that you can fix. And I'm going to help you go about fixing it. I'll walk that path with you. Now, sometimes it's well beyond your scope to manage the shame. And this is where professional help is very important. Okay, so I don't want to say you have only the responsibility here, but you do have an opportunity at the level of an interpersonal interaction to make a difference. Don't intentionally shame people, but don't let their guilt go to waste. Guilt is a very powerful motivator of behavior. We naturally want to get closer to who it is we're trying to be, the standards that we set for ourselves. So don't let that go to waste. Help the person focus on those actions they can fix, practice self-compassion, and then orient them towards growth. And then partner with them, right, in a trusted and an empathic, in a supportive way to go about achieving that growth. The support you provide, it has to be sustained. It can't be one and done. Think about the vignette I showed you. The shame grew over time as the affective emotion withdrew. We often respond with our support when we see emotion externally or externalized, and then as it goes away, we withdraw our support. But if the shame is building as the emotion, the external emotion is withdrawing, and so is our support, we have a gap, we have a delta here. The support has to be sustained, frequent check-ins, coming back to the person over and over, continually getting to that self-evaluative level is really important. And then finally, none of this is going to work well, at least in an environment that's not prepared to support it. So I want you to really reflect on how conducive your environment is to that constructive, wholehearted engagement with and recovery from shame. And I would argue that most of our environments are not conducive to that. We have a lot of work to do, but there's a lot of opportunity in that work. Environments that are going to facilitate that engagement are those in which we prioritize psychological safety. We mitigate competition. We are all out here competing against the impossibility of providing care in our current system, in our current environment, in our current inequities. Let's compete against that, not one another, where we nurture and we facilitate authentic self-expression and identity safety, where we celebrate help seeking, not just facilitate it, we celebrate it, we make it cool and normal, where we provide active support, and finally, where we guarantee for all members that walk into our environments respectful treatment. When we do that, and we leverage that sort of shared experience and relationship, we can transform our environments and the interactions that occur therein. So with that, I'll turn it back over to Jen and any last questions.
Thank you so much, Will. And I think I speak for everyone, and truly a sincere thank you for your transparency. It was certainly a breath of fresh air. I think a lot of people got so much out of this presentation today. Unfortunately, we're butting up against time. So for everyone on this call, Will's information, including his webpage, theshamespace.com, is listed there. Will, if you wouldn't mind flipping to the next slide for me, just to kind of cover some of these announcements. So please complete the evaluation that is going to appear on your screen once the webinar ends. We really value your feedback. And then finally, we've shared the continuing education credit. So to claim your CEs, you'll need to text that code there to the number you see there within 24 hours. That is a key caveat, within 24 hours. So just wanted to share this. And again, give our sincere thanks to Will. Again, I also think I speak for everyone else. We would love to have you back in the future. This was really interesting. Definitely a topic that hits close to home for so many who are supporting our healthcare teams and themselves. So thank you again for all your work, and we hope we cross paths with you again.
Great. Thank you so much for having me and being a really engaged and awesome audience. Have a great day, everybody.